Welcome to the Medication Management During Transitions of Care, Incorporating a Pharmacist into the Patient's Care Team, ADE, conference call. My name is Judy, and I will be your operator for today's call. At this time, all participants are in a listen-only mode. I will turn the call over to Kathy Nichols. Kathy, you may begin.
Thank you, Judy. Hello, everyone. This is Kathy Nichols with Stratus Health, the Minnesota organization that is part of Lake Superior Quality Innovation Network, or Lake Superior QIN. Lake Superior QIN represents Minnesota, Michigan, and Wisconsin under the Centers for Medicare and Medicaid Services Quality Improvement Organization program. I would like to welcome you to this educational session titled Medication Management During Transitions of Care, Incorporating a Pharmacist into the Patient's Care Team. As Judy said, all lines will be muted during this presentation. However, after the presentation, we will have a time for questions and answers. So please, make a note of any questions that may come up as you listen, and you will be instructed how to ask your question at the end of the webinar, or place your question in the chat, and we will try to monitor that as best we can. I am very pleased today to introduce our two speakers for this webinar. Amanda Schroepfer graduated with a doctorate in pharmacy from Creighton University in 2010. She then completed a PGY1 residency with the University of Minnesota and Goodrich Pharmacy. After residency, she was hired by Goodrich Pharmacy to help run their MTM program and staff their Anoka Pharmacy location. In 2015, she achieved board certification in ambulatory care. Today, she continues to work at Goodrich Pharmacy, where she is the site director for the residency program, helps run their MTM program, precepts students, and staff at the Anoka location. Lyn Lais, our other speaker, believes educating the client and community is paramount to providing an easy transition of information between people, their providers, and care systems. She has previously worked at Methodist Hospital as a staff nurse and Walker Methodist Healthcare Center as a transition manager, as well as other leadership roles. Lyn currently works as a life care navigator at LifeSpark, a home health agency, which focuses on the holistic needs of seniors and assisting them to live longer, healthier, and more independent lives. I'm going to begin our presentation by giving you some background on the work we're doing. First, I'll go through our objectives. They are: describe how the pharmacist can assist with medication management at a patient's transition from the nursing home and home health care, identify patients who can benefit from medication therapy management or MTM referral, hear practical lessons from a home health agency's referrals to MTM, and also to help you identify resources to help you connect your patient to an MTM pharmacist. Lake Superior Quality Innovation Network, under contract with Centers for Medicare and Medicaid Services, brings together Medicare beneficiaries, providers, and communities in Michigan, Minnesota, and Wisconsin through data-driven initiatives that increase patient safety, make communities healthier, better coordinate post-hospital care, and improve clinical quality. This webinar will feature work that is being done in Minnesota, led by Stratus Health. According to the Centers for Medicare and Medicaid Services, or CMS, the lack of care coordination in patients' transition from hospitals contributes to nearly 1 in 5 Medicare consumers being readmitted to the hospital within 30 days. Medicare consumers routinely receive medical care from multiple providers in their communities without really knowing or understanding how much the providers are communicating with each other. This can lead to poorly coordinated care, unnecessary medical tests, and increased risk of medication-related problems. Lake Superior Quality Innovation Network is bringing together community partners to collaborate to improve transitions of care and reduce readmissions. Here on this slide, you can see the goals for this collaborate. Improve quality of care among the Medicare beneficiaries who transition among the care settings. We hope to reduce the 30-day hospital readmission rates and admission by 20% by 2019. We wish to increase the number of days for patients to be at home and to establish sustainable, transferable transition practices across the spectrum of care. You can see now on the slide the communities that we've identified in Minnesota that are working on this area. Data was used to drive recruitment efforts for this initiative. Readmission rates for hospitals, nursing homes, and health agencies were analyzed to identify the communities with the greatest opportunities for improvement. In addition, Stratus Health was open to including communities that identified care transitions as a strategic priority for their facilities and populations. You can see from the map that we have 9 communities working on this initiative, with another starting in South Central Minnesota. In Minnesota, then, there are 10 communities with over 940 participants working in more than 30 work groups. You can also see the number and types of organizations involved, spanning the continuum of care and support. Each community has identified areas to work on based on root cause analysis and focuses in their area. The number indicates the number of work groups working in this area across the state. So for medication-related issues, we have 12 work groups working across the state. We've got 5 working on advanced care planning, and you can see the others listed on the slide. These work groups have identified interventions, and here's the list of interventions that they've identified and are in process of implementing. The West Metro community, which is located in Minneapolis, Minnesota, has 4 work groups. Each of the work groups is working on a medication-related intervention. Today we are focusing on one of the work groups, which is focusing on medication management during care transitions. We're going to hear from 2 members of this work group. I'd like now to turn it over to Amanda.
Hi, like she said, my name is Amanda Schroepfer, and I'm a pharmacist that works in an independent pharmacy, actually doing a lot of this work. So I'm seeing patients to complete this medication therapy management appointment in both a community pharmacy and an ambulatory care clinic. So we wanted to kind of start off by giving you just a brief overview about what medication therapy management is for the people that maybe aren't as familiar with it. So basically what it is, it's a comprehensive review of a patient's medications. During that review, the pharmacist assesses for appropriateness, efficacy, safety, and convenience. When we say it's a comprehensive review, we mean everything that the patient takes: prescriptions, over-the-counters, herbal products, medications that may be administered at the clinic, medications that maybe they're prescribed for their husband and that they're taking because they also have that same condition, or maybe they're getting from a friend or a neighbor or a child. We're assessing for appropriateness of all of these medications that they're taking and ingesting. So is it a good choice for this patient given their other medications, given their other chronic conditions? Are they effective? Are we meeting the goals of therapy? Are we doing what we want to do? Is it safe? Does it take into account all of their other medications? Are there drug interactions? Is one of their medications inappropriate or unsafe for a patient with the chronic condition that they have? For instance, if they have diabetes, there are certain medications we would maybe avoid if they have chronic kidney disease or if they have heart failure. So we're assessing that as well. And then also the last thing is convenience. So is it convenient? Can the patient take the medication how we intend them to take it? So is the medication maybe 4 times a day? If it's 4 times a day and they always go play bridge with the card club at noon and they never get that noon dose in, well, that's not convenient for the patient. We would maybe need to choose a different medication that would be better for them. A lot of times hand strength is an issue in patients. So do they have hand strength enough to maybe use an inhaler or another device that they are using to deliver their medications? Are they needing to be taking something with food? Maybe, we've either educated them about that, or maybe they're having a side effect that we can eliminate with just by giving it with food. And then we also talk to patients about costs. So cost is a huge issue for everybody, but especially our Medicare patients. So is there a cheaper alternative to something they're taking, or is there some kind of program that we can get them in, some kind of assistance? And then the last thing that is kind of under that convenience thing is adherence. Are they taking it every day how we want them to take it? Next slide. So we often get questions about MedRec versus MTM. So MedRec and MTM are definitely both very similar, but there are a lot of differences as well. So MedRec involves just creating that list that the patient is taking. So MTM incorporates MedRec. So definitely during the visit we're doing a complete MedRec, but it takes that a step further to assess for those things in the previous slide, like appropriateness, efficacy, safety, and convenience. During the MTM, the patient or the pharmacist works with other healthcare professionals to adjust medication problems that they find during the assessment. So after a visit with the patient, what I generally do is reach out to their primary care provider and all their specialists that they're seeing and help make the changes that we think need to be made that we come up with during the visit. We also talk during these visits about the patient's medication experience. So what has happened in the past that influences the way that patient feels about medications now? Maybe a patient had knew somebody that had severe hypoglycemia with insulin in the past and is afraid to take it. So they maybe don't want to be on insulin or aren't adhering to it because they're really scared of that happening to them too. So we really try to gather that experience from them as well during that MTM visit. Next slide. So next is, why is it important? Why do we need to talk about this, and why do we want to have a pharmacist be on the team? Well, it's because medications are involved in 80% of all treatments of diseases, and drug-related morbidity and mortality costs exceed $200 billion annually in the U.S. So Medicare beneficiaries with multiple chronic diseases see an average of 13 different physicians and have 50 prescriptions filled per year. That's a huge number. And a lot of times these patients are seeing, if they're seeing 13 physicians, they may not be within the same health system. They may be following just one person one time they saw them. And so it's nice to have somebody that can help kind of coordinate that care. And a lot of the work that we do during the MTM involves coordinating care and making sure that we all are taking into account what every other provider is doing. Next slide. So who benefits the most from MTM? Basically, we really think that everybody can benefit from it, but the focus group is the people that maybe have not reached their target goal. So if their blood pressure is not well controlled, or their CHF is not well controlled, they're experiencing a lot of fluid overload, then that would be somebody that would be a good referral to MTM. Patients who are experiencing adverse effects from their medication. So if they're having some kind of problems, that's definitely somebody that we would like to see. A lot of times, if they're having like falls or frequent falling, a lot of times that can just be an adverse effect from medication. So those people we want to see before they end up seriously injuring themselves, or even afterwards, to make sure that the medication that maybe caused it is stopped. Anybody who has difficulty understanding or following their medication regimen is a good referral. So a lot of times people are really confused about what times of day things need to be taken, or which things need to be taken with food, or which things maybe we need to avoid with certain other medications. So it's definitely somebody that we can help kind of sort that out. Anybody who needs preventive therapy, so either prevention of chronic diseases or also vaccines, we definitely talk about that during our visits as well. And then obviously part of this presentation is those who are frequently readmitted or admitted to the hospital. So definitely take a look at the medications that may be causing or contributing to their hospitalizations, and look to kind of help adjust that medication regimen to avoid that hospitalization in the future. Next slide. So I did a little bit of research into a couple of studies that looked at benefit of MTM on hospital readmission. So the first thing I found was that it looked at hospital readmission among 895 elderly home health patients. So patients received a minimum of 2 MTM calls within 30 days of hospital discharge. Patients that in the study were considered low risk of readmission had a 6-fold risk reduction within 30 days and a 3-fold risk reduction within 60 days. So this was that the MTM patients, or the patients that saw an MTM pharmacist, even though they were considered low risk, still had a benefit in readmission. Next slide. The other study that I pulled today was it assessed hospital readmission rates in 90 primarily elderly patients that were discharged to home. So these people weren't receiving any services once they were discharged. They received a phone call from an MTM pharmacist at 72 hours, 2 weeks, and 30 days after discharge. Patients that were put in the MTM group had a readmission rate of 7% compared to patients that did not have a visit with a pharmacist, and they had a readmission rate of 20%. So we're really seeing that there is a lot of benefit as far as readmission goes for patients to see an MTM pharmacist. Next slide. So then, question is, how do patients get an MTM appointment, or how do we get patients connected to a pharmacist that do this service? So many community pharmacies provide this service. Like I said, I work at a community pharmacy, and we definitely see patients in our community locations frequently. And there are a lot of pharmacies that provide this work. So the way the patient would find out is just they could call the pharmacy and ask them if they provide the service or if they would be willing to meet with them. And then the other way is that most health systems do have pharmacists that work in their clinics to provide the service as well. So ambulatory care clinics. So if the patient is seeing primary provider at one of the ambulatory care clinics, definitely most of them do have pharmacy, especially in the metro area, that kind of work with them as well. Next. So that kind of brings me to our referral list. So this referral list was generated from a group of pharmacists at Stratus, and it's basically a list of health systems in the metro area, and some of them outstate too, but so all the health systems on the left-hand side of there, and then the MTM scheduling line. This list is also on the handout that was sent along with the webinar link information, the Word document. But basically the patient could use this list to, if they saw a provider at Fairview, they could use this list, call Fairview, and schedule an appointment with a pharmacist. The Word document that was handed out at the webinar also has information that can be given to patients explaining what an MTM visit is, why they need it, who benefits from it, and it just gives them good information. So that list is intended to be able to be handed to patients or their caregivers to help them connect with a pharmacist and explain why it's important and why it's needed. Next slide. And the last thing I have for you is the cost of the visit. So what is the cost? MTM is a required benefit for Medicare Part D patients, and most plans provide this to the patient for no charge. So definitely most of our Medicare Part D people that are covered under Medicare Part D will have this as a benefit on their insurance. Many patients can be seen at clinics as well, and a lot of times the clinics are providing this service as well. So they definitely want the patient to reach out to their insurance company and the clinic to check for the charges, because most of the patients can be seen at no charge. And then I'm going to hand it over to Lyn. So she is going to talk a little bit about some practical uses of the MTM referral list and kind of her experience using the list.
Great. Thanks, Amanda. So I'm a registered nurse, and I work with clients through a couple of different transitions. I'm working with clients that have transitioned from a skilled nursing facility or transitional care unit and are returning back into the community. And I have been utilizing the MTM referral contact list that we saw on the previous slide, and assisting the client at the time of discharge as we're preparing for discharge and talking about the follow-up appointments with the primary care physician. We also are talking about the MTM referral and the appointment with a pharmacist. So we have now really started helping the client and family to understand the referral list and assist them if needed with making a call. And some of the systems that I've worked with on the list, I've worked with the Fairview system, North Memorial, and the Park Nicollet system. And the one thing I can say about all of the calls I've made is everyone has been so helpful in walking through the process, answering questions about the charges or how to go about determining if this is a covered service. So calling the individual number will give a lot of information. one of the things I learned from the Park Nicollet referral number is that when we are trying to set up an appointment for a client for that first 7-day visit post-discharge with their primary physician, the Park Nicollet pharmacist calling the number on the referral sheet will also assist you with scheduling that primary care appointment so that both of those can be set together and within that first 7 to 10 days. So that has been very helpful. I've gotten many positive feedback comments from families and clients using that system. I've also worked with clients transitioning into a home care episode, and I work with clients to set up their private pay home care, for example, and so referring a patient that has not come out of a transitional care unit, it's just as simple. What it does take for the home care nurse or the care team working with a client, it takes a little bit more discovery with a client at home prior to setting up the appointment. We really want to make sure that we're sitting down with the client and family and obtaining all of their medication lists, understanding what specialists they go to that may be outside of their primary care clinic. For example, a client I worked with recently follows with the Park Nicollet Methodist Clinic but has ophthalmology through the Fairview University system. So we make sure that we have the name of the providers at each specialty clinics and their phone numbers, understanding what medications they have been in charge of ordering, putting that list together almost in a folder, and getting as much information to send with the client and family at the time of the referral. And then we make that referral. And I've found that that has been so successful in helping the pharmacist and the patient to have a good experience. If we do a little of that research and discovery prior to setting up that appointment, and then when we set that appointment up, I'd even call to say I'm the home care nurse, give them my contact number, and they have called me back with an update and kept me in the loop. And so we're working together, the primary physician, the client, the pharmacist, and myself. And that's all with approval from the client, obviously. So we've had some very good preliminary experiences. Those are some examples. Thank you.
Thanks, Amanda and Lynn. If you go to the next slide, you'll see the references that Amanda referred to during her presentation. Thank you very much. It was very helpful to hear this background and how the referrals are being used. We now have time for questions or comments for our speakers. Operator, can you tell our participants how to get into the queue for questions or comments?
Thank you. We will now begin the question and answer session. If you have a question, please press star then 1 on your touch-tone phone. If you wish to be removed from the queue, please press the pound sign or the hash key. There will be a delay before the first question is announced. If you are using a speakerphone, you may need to pick up the handset first before pressing the numbers. Once again, if you have a question, please press star 1. We're going to stand by for audio questions.
Amanda, I have a question for you while we wait to see if there are other comments. You are in a community pharmacy, and I don't often think about the community pharmacist as having a lot of connection with that provider. So can you talk about how you share information, especially if you're seeing a new client in the pharmacy for the first time?
Sure, yeah. So one of the things that we always do when we're seeing our patients in the community side is we actually ask that during the visit the patient would bring any information that they have. So if they have their discharge information or anything like that, we ask them to bring any records that they have with them. The other thing that we do is we actually request records from all of the physicians or providers that they see. So when they meet with us, we have them fill out a release of information form so that we have access to all of the notes from their providers and all the doctors that they see across the health system. So we usually get that information fairly quickly from the medical side, and then once we have that information, we can assess that along with kind of the information that we gather from the patient during the visit. So it is just a little extra step that we have to do because we don't have access directly to the medical records through the primary provider. But definitely we take the time to get those records from everybody so that we can see the full picture of the patient while we're meeting with them. And, you know, we talk through their medications, and we can do a lot of the assessment without seeing some of the labs and stuff, but definitely when we get that information, if there's any changes to the plan, we let the patient know.
Thanks, Amanda.
Yeah.
Judy, do we have any questions?
Kathy, we have no questions at this time.
Okay. I think we will conclude for today. Thank you again, Amanda and Lyn, for sharing with us today. As you exit from this webinar, a window will open to a short evaluation. There's also a link to the evaluation in the chat box. Please take a minute to provide feedback on today's session and answer some questions on your experience with MTM referrals. Once you've completed the evaluation, you will receive a certificate of participation. In approximately 4 weeks, you'll receive another brief questionnaire from Stratus Health asking if you've completed any MTM referrals following this educational session. We thank you for your participation today and hope you found the information relevant to you and the people you serve. This session was recorded and will be available on the Lake Superior QIN website in about 2 weeks. Thank you all for participating and have a great afternoon.
Thank you, ladies and gentlemen. This concludes today's conference. Thank you for participating.